Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, March 16th, 2018, for our UNC Community Lunch and Learn lecture. A few details before we get started. If you are running into any technical difficulties at all, please call us 919-445-1000. We want this whole lecture to be a great experience. We don't want any garbled audio or problems with the video. So call us, let us know right away. We have folks standing by who can help if there is a problem. We have lots of different ways you can find us. We're on the web at unccn.org. That's probably the best place to find us, but we're on Facebook, we're on Twitter, we're on YouTube. We have well over 200 lectures now that have been recorded on a variety of different oncology topics that you can find there. So we do hope you'll visit us, ask questions, find out more. All right, and speaking of questions, well, I want to talk about one other thing first, which is if you are a media site viewer viewing the live stream, I just want to remind you that up in the upper right-hand corner, you've got a few controls there. So if you're just seeing the video or just seeing the slides, you can see both. You can go ahead and click on one of these icons. This little rectangle and rectangle will give you one inside the other, either the slides in the video or the video in the slides. If you want to switch that around and see the video bigger, the slides smaller, these two little arrows will take care of that, and you can switch views. You can just see video or slides, and you can see both side by side. So we just want to make sure our media site viewers know about those controls. We'll be using Poll Everywhere today, and this will give you an opportunity to answer a variety of different questions and then ask questions at the end. I am extremely pleased to say that our presenter today has prepared several different questions for you. We think this will help inform you along the way and make it a truly engaging presentation. So I hope that each of you out there, if you have a smartphone, you can do this. If you have a computer, you can do this. And if you have a computer, you can just go to pollev, POLLEV.com/UNCCN, and you can go ahead and join and see the various questions and answer those on your computer or smartphone. Most of the time, our audience uses a phone, any type of phone, that has texting capabilities, and you're going to text in the to field, the number 22333. Just do this once, and in the message field, you'll put in UNCCN. So if you'd like to be asking questions and answering questions, go ahead and do that now. In the to field 22333 and the message UNCCN, you'll get a little message back saying that you've joined, and then you can go ahead and participate in our initial poll question and then questions throughout the presentation. So, with that in mind, our question will be, according to the American Cancer Society, colorectal cancer is the blank leading cause of cancer-related deaths in men and women in the United States. And so if you think that is the first leading cause, you would put A, second leading cause B, third leading cause C, or fourth D. So A, B, C, or D. This is all anonymous, but that we'd love it if you go ahead and participate with us in Poll Everywhere and let us know what you think that answer might be. All right. And without further ado, I would like to introduce our speaker today, Tammy Triglianos. Welcome. Hey, good to have you here. Good to have you back.
Yeah,
you're alum here with us at UNC Cancer Network. Tammy Triglianos has worked as a certified nurse navigator in the gastrointestinal oncology division at the UNC Lineberger Comprehensive Cancer Center since 2008. She holds a dual certification as an adult nurse practitioner as well as an oncology certified practitioner. She also serves as an adjunct faculty member in the UNC School of Nursing, where she mentors nurse practitioner students. Her area of expertise is working with patients undergoing chemotherapy treatment with GI cancers. She is involved with the patient from diagnosis through active chemotherapy treatment, assisting with symptom management through survivorship. Her clinical interests include working with patients on clinical trials, survivorship, and quality of life while undergoing cancer treatment. So maybe you can tell us just a little bit about what led to your interest in oncology nursing.
So I have been interested in helping care for oncology patients since the beginning of my career in starting my nursing education back in my early 20s. I never had a family member who had undergone cancer at that time, but I just had a strong interest in helping people through a diagnosis that could at times be terminal and be able to help navigate and support them through probably one of their most challenging moments in their life.
Well, we're very glad you did, and we're glad
you.
to have you here today. So let's take a look at that poll and see. Again, according to the American Cancer Society, colorectal cancer is the first, second, third, or fourth leading cause of cancer-related deaths in men and women in the United States. And if you'd like to take just a moment to share what you think would be the answer on that poll, that would be great. Let me make sure, and that is active. So we don't have any responses in yet, and we may still have people getting set up for poll everywhere. Do you want to go ahead and let them know what the answer to that is?
So the answer is B, second.
Okay.
It is the second leading cause of cancer-related deaths.
Okay. All right. Well, thank you. Hopefully, as we move through the presentation, you'll take advantage of, we'll pop up some more polls, and you can go ahead and let us know what you think about those as we go through the presentation. Well, colorectal cancer, what you need to know. With that, I'll go ahead and turn this over to you.
Great. Thank you. So good afternoon. Thank you all for joining me. I appreciate the opportunity to talk with you all about colorectal cancer and almost everything you need to know. Our objectives today are, by the time I'm finished with my discussion, I hope you'll have a good understanding of the most common signs and symptoms of a colorectal cancer. I hope you'll be able to understand risk factors and screening and early detection and the importance of those things. We will discuss colorectal cancer staging and how we stage a cancer and some basics of cancer treatment. And then lastly, moving on to survivorship and healthy and lifestyle interventions.
All right, so we'll pop up our first poll question there, and that is, and we already have an answer on that. So April is Colon Cancer Awareness Month, and if you think that that is true, go ahead and give us an A, and if you think that's false, go ahead and give us a B. And I will say that it is possible, I'm guessing it's likely, that we had a question filter in from or an answer filter in from the last question.
Okay.
So that's possible.
Okay.
Wait a few more seconds, and then again, as now that you know these are coming, we hope you'll text that 22333 with the letters UNCCN and join and try some of these other polls out. So what's the answer on this one?
That's correct.
That
false.
is correct.
I tried to trick you all, but I hope you saw my No, April is not Colon Cancer Awareness Month. March, the month we're in, is Colon Cancer Awareness Month. Back in 2000, President Clinton did declare March as Colorectal Cancer Awareness Month, and I'm wearing my blue today to support that.
Great.
So here's our agenda for today. I'll pause for a minute for you to review. First, we'll begin with an overview of colorectal cancer, which does refer to a malignant or cancerous area of the colon or rectum. Many times these are termed and grouped together, but really they are two different cancers based on where they started from, and they're ultimately treated differently. To review some more statistics on colorectal cancer, it is the third most common cancer diagnosed in men and women in the United States. As we know from our first poll question, it is the second leading cause of cancer-related deaths. A lifetime risk for men is about 1 in 22, and for women is 1 in 24. There are more cases diagnosed in the colon, about 71%, and less common diagnosed in the rectum, about 29%. But the good news is survival rates are improving over time as we increase awareness and screening, and one of the important reasons I'm here today. So I want to first point out that our new cases of colorectal cancer diagnosis are most common in the age range of 55 to 85. And that's important to remember as we talk about our screening guidelines. So moving on to risk factors, which do include some genetic and non-genetic factors. I'd first like you to note that having one of these factors does not guarantee that you will get a cancer. And not having one of these factors does not guarantee you won't get a colorectal cancer either. So some non-modifiable risk factors, or factors that you have no control over or can't change, is age. More than 90% of our colorectal cancer cases are in people age 50 and older. Personal history is another risk factor. A familial factor is people with a first-degree relative, a parent, a sibling, a child who have had a cancer have a 2 to 4 times higher risk of developing a colorectal cancer. And that risk even increases with multiple first-degree relatives who may be diagnosed. Next is hereditary syndromes. There's a small percentage of colorectal cancers that are related to a genetic abnormality. The most common is Lynch syndrome, and the second most common is familial adenomatous polyposis, or the easy way to say that is FAP. Further risk factors include a personal history of adenomas or polyps, as well as inflammatory bowel disease, for example, ulcerative colitis or Crohn's disease. When we look at those non-modifiable risk factors, based on incidence, the most common are sporadic. They happen for no clear reason, which can be frustrating sometimes. And the next most common is familial. It's happening in families, but not necessarily with a genetic abnormality. And less common are hereditary cancers that have a genetic abnormality. That's usually it's about less than 10%. So moving on to modifiable risk factors, or those factors that you do have control over and can change. One is lack of physical activity, obesity, increased consumption of red or processed meats, smoking cigarettes, alcohol consumption, and diets that are high in fat or low in fiber. So how do we screen for colorectal cancer? I'm first going to poll my audience again to understand that the age of my audience are less with 50 being the midpoint, less than age 50 or older than 50.
All right. Y'all are quick there. We're already getting some responses, so thank you so much. Again, this is all anonymous, but thank you for sharing that.
And then my follow-up question for you all is, how many of you had a screening colonoscopy? You're making me happy today. Thank you. Oh, I spoke too soon. So this is
kind of fun because we get to see this all in real time.
Yeah.
But of course, not everyone in the audience would necessarily would it have been recommended for then, I'm assuming.
Well, with 50 years or above, which I'm about to explain to you all. And So that's interesting, and that fits with what I'm about to talk to you about. So some things to note about colorectal cancer screening. Many times colorectal cancer is not diagnosed until it's more advanced. It doesn't cause symptoms till it's in a more advanced stage. And it's really important to detect this disease early and diagnose it early, as this greatly affects survival. Only half of the U.S. population participate in survival, which that coincided with our poll question. And it is important that regular screening occur when colorectal cancer could be found early on the more early side when treatment is more effective. So recommended screening is regular visits with a primary care provider to include a physical exam and health history. It's important to have an ongoing relationship with your primary care provider, even if you feel you're healthy and you have no medical problems. Being able to identify any change in symptoms, even subtle ones, can detect a colorectal cancer on the earlier side. So adults beginning at the age of 50, it is recommended to begin with fecal occult blood or fecal immunochemical tests on a yearly basis. This is a test that can detect microscopic blood in the stool that may not be visible to the naked eye. Further recommendations include a flexible sigmoidoscopy or colonoscopy every 5 to 10 years. This can detect colon polyps and remove them early before they can change into a cancer, or even identify a cancer at an earlier stage when it tends to not cause any symptoms. And newer are stool DNA tests. I don't think these are routinely done by primary care providers, but can certainly be done as recommended by your provider. I'd also like to point out that although screening is recommended at age of 50, it may begin earlier based on your personal or family history. For example, if a family member was diagnosed with a colorectal cancer at age 40 and they had children, their children should be screened starting 10 years earlier than the age of the person diagnosed. So at age 30, those children should have colonoscopy screening. So I cannot stress the importance of screening in a colorectal cancer. It's important for finding and removing polyps to prevent a colon cancer from forming, and it can detect a cancer at an earlier stage. So moving on to some signs and symptoms of colorectal cancer. A change in bowel habits, such as diarrhea, constipation, narrowing of the stool, and these are symptoms that may last longer than a few days. Another feeling of incomplete evacuation, or I feel like you have to have a bowel movement and that pressure is not relieved by doing so. Cramping or abdominal pain, that's ongoing. Rectal bleeding, dark stools or melena, or blood in the stool. Extreme weakness or fatigue, or unintended weight loss. And these are pretty common signs and symptoms, fairly general, and just because you have one of these symptoms doesn't necessarily mean you have a cancer. But I think it does warrant a conversation with your primary care provider and further testing and screening if needed. So diagnostic testing, how do we identify or work up a colorectal cancer? So we talked about colonoscopy used in screening. For one of those previous signs or symptoms, a colonoscopy may be warranted to evaluate one of those symptoms. And biopsy of any suspicious lesions, and blood work. A complete blood count would identify any anemia if there was some bleeding from a cancerous tumor. A comprehensive metabolic panel, which could evaluate kidney or liver function, some electrolyte abnormalities. And a CEA. A CEA is a tumor marker. It's a marker found in blood and is not always identified when a cancer is present. It is not used as a screening marker, but can be used during cancer treatment to evaluate response to treatment. But it's not a 100% specific or sensitive test, meaning people who have a cancer may not have an elevated CEA, and those without a cancer could very well have a mildly elevated CEA. For example, people who smoke or have an inflammatory bowel disorder or diverticulitis may have a mildly elevated CEA. And then the other tests could be imaging, including a CAT scan, which would evaluate for any spread of the cancer. So we'll discuss staging of colorectal cancer. Staging includes what's called a TNM system, with the T being used to indicate the size or extent of the primary cancer, the N indicating lymph nodes or spread to nearby lymph nodes, and the M for metastasis or spread of the cancer to other parts of the body. A number is added to these letters to indicate extent of each of those indicators. For example, we'll look specifically at how this translates into stage when referring to colorectal cancer. As you can see from this chart, a stage 1 cancer has a smaller tumor size or extent of invasion. You could see in the picture below, down here, stage 1, much smaller, has not spread to lymph nodes or other parts of the body. And likewise in a stage 2, a little bit larger side or depth of invasion, meaning spreading into the wall of the colon. Again, no lymph node or other parts of the body involved. A stage 3 cancer can technically be any size primary tumor, but now the cancer has spread to nearby lymph nodes. And then a stage 4 cancer, again, any size primary tumor, they tend to be larger in size, but they've involved the lymph nodes and then have spread outside this primary site to a distant organ. So we'll move on to treatment. And there are different types of treatment for patients with colorectal cancer. Depending on stage and location, the oncologist may recommend one or a combination of the following treatments. First is surgery, which is used to remove the area of cancer. Next is radiation, which uses high energy X-rays or other types of radiation to kill cancer cells. Chemotherapy, which can be by mouth or IV, which is used to kill cancer cells and stop the growth of cancer. And then targeted therapy, which are medications that are not chemotherapies, but may be used to target certain markers that are seen on cancer cells. So looking at treatments based on stage, a stage 1 cancer, the primary treatment is surgery, removal of that area of cancer. And this has about a 92% 5-year survival rate, meaning that at 5 years, 92% of the people will still be alive. A stage 2 cancer Again, surgery is the recommended treatment to remove that primary cancer, and this has about a 63 to 87% survival rate at 5 years. A stage 3 cancer does use surgery to remove that primary cancer, but because a stage 3 cancer has now moved into the lymph nodes, chemotherapy is given to try to prevent that cancer from coming back and to kill any microscopic cells that might not be visible or removed during that surgery. And this has a 5-year survival rate of about 53 to 89%. And then a stage 4 cancer, primary treatment is usually chemo plus a targeted agent. And sometimes surgery can be used in a stage 4 cancer to remove an area of metastases or spread, but a much lower 5-year survival rate for a stage 4 colon cancer, about 11%. Hence my stress of this lecture to stress the importance of cancer screening, colorectal cancer screening. So our next poll question is a true or false. 1 in 3 cancer deaths from colon cancer could be prevented with early detection. Yes, correct. That is true. Being able to prevent one of those cancer-related deaths is really important, and that's where screening plays the biggest role. So I thought I'd share some case scenarios and put this into real-life situations. Our first case scenario is a 61-year-old male. He had regular screening colonoscopies every 5 years. He had regular follow-ups with his primary care provider and an ongoing relationship with him. But his most recent screening colonoscopy, he was found to have a colon mass. His diagnostic workup included a biopsy of that mass, which did confirm that it was an adenocarcinoma or cancer. He did have a CAT scan as part of his workup, which did not show that this cancer spread to any distant parts of his body. The treatment recommended for him was surgery to remove the cancer. He was diagnosed with a T3 based on size. It did not spread to lymph nodes or metastasis, so this was a stage 2 colon cancer, and no chemotherapy was recommended. Chemotherapy in a stage 2 colon cancer has only shown to have a 4 to 5% benefit. So that would be a lot of chemotherapy given to people who don't really need it. Our next case scenario is a 64-year-old female who is a smoker. She did not have regular visits with her primary care provider. Her last colonoscopy was about 15 years ago, in which she did have polyps removed, another risk factor. She ended up going to an emergency room with abdominal pain, nausea, vomiting, and constipation, which was ongoing for about a week and a half. Her diagnostic workup included a CAT scan, which did show a bowel obstruction, and but did not show that this cancer has spread to other organs. She had a sigmoidoscopy, which identified the mass, and a biopsy, which confirmed an adenocarcinoma. Treatment recommended was to remove the primary cancer, but during her surgery, she was found to have lymph node involvement. That's that 2 on the N, and this translated into a stage 3 colon cancer. She then received adjuvant chemotherapy, or chemotherapy after her surgery in adjunct to decrease her risk of cancer recurrence and trying to prevent this cancer from coming back. Moving on to our last case scenario, a 57-year-old male who never had a colonoscopy, did not have regular visits with his primary care provider. He did have a grandmother with colon cancer, so not a first-degree relative, but still a relative. And he reported a history of intermittent black stools or rectal bleeding over the past 6 months. He then went to an emergency room with weakness and shortness of breath. His diagnostic workup included blood work, which showed him severely anemic from blood loss from his primary colon tumor. His CAT scan showed a colon mass and disease in his liver, so it had spread outside the primary site, and a biopsy did confirm an adenocarcinoma. Treatment recommended for him was systemic chemotherapy, a combination of medicines, plus a targeted agent. So I think it's important to share with you all that chemotherapy can work. It can be effective in prolonging life and shrinking cancer. So on the before picture, this is his CAT scan. This is a picture of his liver. The dark area is cancer. So you can see a pretty large area involved with cancer. And this lighter area is normal liver tissue. After a couple of months of therapy, he had a follow-up CAT scan. And his follow-up CAT scan showed this. That area had shrunk down to this smaller area, much more lighter area, which is normal liver tissue. And I have to say, even despite side effects from chemotherapy, this gentleman's quality of life had greatly improved. He was more energetic. He was able to be out and about and back to his hobbies and enjoying life again, and eating better and not losing weight. So we really had a positive impact on his quality of life. So I'd like to briefly mention other treatment options for advanced colorectal cancer. You'll probably see a lot in the media about immunotherapy. Immunotherapy can be used in colorectal cancer. It's mostly used in a very small select population of colorectal cancers that are what's termed MSI high or microsatellite high, which is less than 10 to 20% of colorectal cancer diagnoses, so not used very often. And other options could be clinical trials or research studies, which are used to improve cancer treatments, to look at new cancer medicines, or different combinations of medicines that may not have been used in the past. So moving on to survivorship, or life after a cancer diagnosis, this can be pretty challenging as it's different for everyone. Survivorship begins at diagnosis. It includes people who may be on long-term treatment and have an incurable cancer, or those that have completed treatment. Survivorship includes surveillance and prevention of a cancer recurrence, surveillance of medical or psychological effects of a cancer or even a cancer treatment. It includes interventions for late or long-term effects of cancer or cancer treatment, and involves health promotion and quality of life. One of my strongest points of taking care of cancer patients is quality of life, whether that's with treatment or without. To briefly discuss some long-term or late side effects of cancer treatment, I put anxiety at the top. I think that's one of the most common feelings a cancer patient has, whether you're dealing with a cancer diagnosis and ongoing treatment or have finished cancer treatment. Fear of a recurrence, fear of what's next or how your life is going to play out. Fatigue or low stamina, another common side effect. And I think this is one that tends to linger the longest after a cancer treatment and someone has completed cancer therapy. They may be able to do all the things they want to do, but may take a little bit more effort, and notice they kind of wear out a little bit more easily. Peripheral neuropathy can be common, in particular with one of our chemotherapy agents. Can also be an issue from surgery, from nerves being involved, or even radiation as nerves are involved there. And then that can lead into some urinary incontinence, sexual dysfunction, or even change in bowel function. So these are all important aspects of cancer treatment, even getting through a cancer therapy, that need attention and helping people with quality of life. So we'll review follow-up care guidelines for people who have had a cancer, they've had their cancer removed, and have gone through a cancer treatment, whether it's chemotherapy or just surgery. For the first 5 years after a cancer diagnosis, we recommend people to have a history and physical exam with their oncologist every 3 to 6 months. A CEA, which is blood work, every 3 to 6 months with each visit. And a CAT scan on a yearly basis of the chest, abdomen, and pelvis to evaluate for early disease recurrence that may not be symptomatic. And continuing with colonoscopy at 1 year, and that 1 year is from their cancer surgery, and then repeating about every 1 to 3 years, depending on if polyps were identified and removed, we would recommend more frequent colonoscopy screening. And after 5 years of treatment, most of the time, these people don't need an oncologist anymore, and they can return to their primary care provider for ongoing follow-up and healthcare maintenance. So health promotion in survivors. I spend a lot of time discussing this with my patients. So achieving and maintaining a healthy weight, engaging in regular physical activity. I talk to every single person about being active. And this may include just walking, but walking to get your heart rate up. That's where you gain the most benefit. Strolling through the mall doesn't count. A brisk walk 4 to 5 times a week. And over time, the goal would be to increase that for those people that really have significant fatigue or low stamina from their cancer treatment. Maintaining a healthy diet to include fresh fruits and vegetables and whole grains. Avoiding tobacco. Avoiding or minimizing alcohol consumption. A low-dose daily aspirin, which can prevent polyp formation and even reduce long-term incidence or mortality from a colorectal cancer. And recently it was found that tree nut consumption can provide benefit in decreasing risk of colorectal cancer recurrence. And this doesn't include peanuts, because I hope you all know that that's a legume, and tree nuts include pecans, walnuts, almonds. So something simple and easy to do a couple times a week. So what I'd like you to leave here today with is understanding risk factors, get screened when appropriate, having that ongoing relationship with your primary care provider so you can consult them, live a healthy lifestyle, and please leave here today and go out and educate your friends and family on screening. And thank you for joining me today.
All right, Tammy, thank you so much. We really appreciate it. So I want to remind our audience that now you can go ahead and share your questions with Tammy via that same poll everywhere mechanism. So you just, if you didn't do it at the beginning, the number's 22333. You text the letters UNCCN. You'll get a reply that said join. If you already did that, you're all set. You can just go ahead and share those questions. This was great, and I did have a few things I wondered about. You mentioned with survivorship anxiety. What are some of the mechanisms that you found effective for somebody to deal with the anxiety that they may feel around survivorship and around that? I imagine some of the physical side effects that they'd be experiencing as well.
Yeah, I mean that's a very complex answer, and I think for people it's very different. So having a conversation, getting people to even be able to admit that and talk about it. We do have our Cancer Resource Center, which works with cancer patients, whether before, after, during treatment, if kind of talking with somebody in therapy is something that helps in their coping mechanism. Again, I'll go back to physical activity. I'm a huge believer that getting out in the sun, some vitamin D, that fresh air, getting your heart rate up, can really help people's mind, body, and soul.
Yeah.
And that looks different from everybody. You know, some people it's yoga, some people it's cancer support groups, talking with other people that have been there and done that. It really varies, and I try to tailor that to the person who's sitting in front of me.
Sure. I know we've had a few lectures here on mindfulness in recently. So has that been something that you've seen as well that's been effective?
Yeah, for a particular subset of patients,
Gotcha.
I think mindfulness can be hard for a lot of people.
Sure. And as a shameless plug for some of our other presentations, we have had presentations that you can watch online, some of the recordings on mindfulness, and also Dr. Bottiglini and others talking about fitness and the role there. So, all right, we've got a question. You mentioned radiation as a possible treatment. At what point in the treatment pathway would that become an option?
So radiation is used in rectal cancer, and I apologize, I probably should have been a little bit more clear. In the beginning I did mention that a colon cancer and a rectal cancer are a lot of times combined together, but ultimately they do have different treatment options. And radiation is more commonly used in a rectal cancer patient to decrease that primary tumor, which can make a surgery easier. And the other way radiation can be used in a colon cancer, whether it's an area that has spread that's pretty large that might be causing pain. So it can use for palliative reasons or symptom management to shrink an area of spread down, or that may have invaded a organ or outside the colon to decrease a local recurrence. So a couple different ways radiation can be used.
All right, that was a great question. Thank you. And then another question, I'm guessing this one may be situational, but what is the best colon screening method between the three?
Yeah, so certainly agree that it depends and can be very individual. Colonoscopy screening, that's why one of my poll questions was how many of you have been screened. I really wanted to stress the importance that although it may not be pleasant to prep for a colonoscopy screening, it really can pick up on a small cancer that isn't causing symptoms and where survival is much improved. Great.
Other questions? We've got a couple more minutes. Oh, here we go. Do you recommend aspirin for colon cancer prevention?
Yes, with the caveat that there's no contraindication or reason why you shouldn't take an aspirin. And this is a baby aspirin, 81 milligram once a day. If there's no other risk factor, stomach ulcer, any stomach bleeding or gastritis or irritation to the stomach lining, a baby daily aspirin can certainly be helpful. I always encourage my patients to have a discussion with their primary care provider as well to discuss any contraindications for not taking aspirin.
And I believe there was some research that came out maybe 4 or 6 months ago that was pretty significant on this. I mean, this, at least some of the things that I had read, it wasn't like a 5% decrease. It was a large percentage decrease with folks who take just that baby aspirin on a regular basis.
Yes. Yeah.
So certainly we encourage our audience to look at that research that's out there. But I was impressed with whatever those numbers were. I remember they were high.
Yeah.
All right. Any other questions that you may have? Okay. Well, we want to thank you all for being a great audience today. One more. Do stool softeners cause any damage in the colon? Great question.
No, not that I'm aware of. I think they're certainly safe. I recommend them to my patients.
And if somebody who was listening today wanted to find additional resources, either about prevention or treatment of colorectal cancer, any particular places you might recommend they go?
Certainly the American Cancer Society has accurate information and up to date. And
great. All right. Well, I want to thank you all for being here. Your feedback, we really count on your feedback. Please take a couple of minutes to visit. We've got the website, the link here, and you'll find that on the presentation. If you go to unccn.org and click on Tammy's presentation, you'll find a place for that evaluation. And you can also do that. So you'd go to unccn.org, click on events, find the lecture, and then scroll down and click on the survey. We really count on you to let us know how we're doing, let Tammy know how she's doing, and give us that feedback so that we can continually evaluate and improve our programs. All right. Let's see. Remember, we also have our learning portal, learn.unccn.org, and that's another place that you can go and find our lectures in addition to our website. Next month, April 27th, 2018 at noon, Hospice Care and Caring for the Dying and Their Family with Nicole Sartor. So we hope that you'll join us then for that presentation. We do want to thank the North Carolina General Assembly for their generous support of the UNC Lineberger Comprehensive Cancer Center and the UCRF, what we call University Cancer Research Fund. We want to thank Mary King, Veneranda Obore, and John Powell for all the hard work that they do to make this and every one of our lectures possible. We're on the web, Facebook, Twitter, all over. We hope you'll find out about upcoming lectures, maybe sign up for our newsletter, view some of our past lectures, and we appreciate your support and involvement with this program always. So thank you for being here today, and thank you, Tammy.
Thank you.